Hello and good morning, everyone. My name is Jeff. I'm the director here at Insight. It's my great pleasure to welcome you to our special bonus Insight AppSAD webinar today. Natasha, I'll get you to skip to the next slide for me, please. We have a lovely bunch of panelists here who are going to wave hello in a second, but before that, I'd just like to quickly acknowledge the traditional custodians of the lands across Australia, where we all come from today, and pay our respects to elders past and present. I'd also like to recognise our colleagues with lived and living experience and their contributions to the work and the reason why we're here doing what we do. Next slide, thanks, Natasha. So yes, we have a whole bunch of esteemed speakers today who will all be contributing their little part. If everyone would like to turn their cameras on and say a quick hello, we've got Professor Doug Shelton, Dr. Natasha Reid, Associate Professor Delise Hutchinson, Prue Walker, Dr. James Stewart, and Max Naglazas. Hopefully I got that correct. So hi everyone, they'll take their turns. If we will be dropping a copy of the PDF presentation into the chat where you can download that, and we'll have that available at the end. In the chat, you can list some questions, and there'll be a Q&A session at the end of all of the presentations where all of the speakers can address them. So drop that into the chat function and we can answer them as we go. If you've got any technical issues, drop that into the chat and we'll address that in the background. But apart from that, we'll hand it over to you, Doug, to kick off the presentation.
Okay, thank you, Jeff. Tash, if you could just skip through a couple of slides. Okay, yes, so it's my great pleasure to introduce this webinar today to talk about the Australian guidelines for the assessment and diagnosis of FASD 2025 version. So Tash, next slide. We'd also like to acknowledge the First Nations people of the beautiful lands you are joining us from today, wherever you happen to be. We acknowledge the enduring knowledge and connections to country of all First Nations people. And we honour the wisdom of and pay respect to elders, past and present, and also future leaders working alongside the elders. We recognise all First Nations people as the original health practitioners of these lands, and acknowledge the important continued role in our services and in our communities. And I think you will see that this has played out extensively in the development of the guidelines. Next slide. So I'd also like to acknowledge the people on this slide. I won't go through them all individually, but the research team in particular led this project. The project took a little bit longer than was anticipated, so it's a tribute to their persistence and particularly their fortitude and integrity in the face of some adversity that we've arrived at today. So congratulations to them. There were extensive steering committee, advisory groups and guidelines development groups who are too numerous to list here, but who are all outlined in the guidelines. We'd also like to acknowledge the Digital Journey Photography Group, and most importantly, pay tribute to the Australian Department of Health and Aged Care, who saw fit to fund an up-to-date version of the guidelines, as well as Isaac and Daniel, who contributed heavily to the artwork. Next slide. So, why did we need new guidelines in the first place? The reason for that is that there were multiple guidelines from around the world, none of which particularly agreed with one another. And none of them were fully evidence-based. There was some evidence and there were some elements of evidence in them. And so when first assembled, our stakeholders agreed on the need for more holistic guidelines and for individual assessment processes that could be utilised across a variety of settings. So we wanted to move away from the concept that if you needed an FASD assessment, you had to relocate to your nearest capital city, because clearly that is just a very impracticable idea. And also what clearly came through was the need for culturally responsive assessment practices. Next slide. And so they were the needs. This is what people said, and this is what we've delivered. The key changes are that the new guidelines are holistic and inclusive, in particular embedding First Nations perspective. And the new guidelines allow assessment processes that can be completed across different contexts. It is not metro-centric anymore. We've also carefully looked at the evidence, and probably the most controversial area is the minimum amount of prenatal alcohol exposure required for a threshold. And that's been a result of a very rigorous, systematic, and detailed evidence review, probably the most rigorous that I've ever had the pleasure of being engaged in. So my compliments to all the people engaged in that. And also providing some flexibility in diagnostic terminology. Next slide. So the foundational considerations which permeate the guidelines, you can see here, and an Indigenous framework with a human rights perspective, shared decision-making, utilising the ICF framework, incorporating all the key elements of developmental psychopathology, as well as risk and disease elements. And I'm sure when you read the guidelines, you will see these underpinning nearly everything that has been done. Next slide. And I would draw your attention particularly to this document, which was led by Nicole Hayes, but also many other people. It is excellent reading, and I highly commend it to all of you. And it was developed separately as an additional resource, but it also informs the guidelines in their text. So with that note, it's one of my great privileges to have worked as part of the guidelines group that was ably led by Dr. Natasha Reid, who will take over the presentation from here in. Thank you, Tash.
Awesome. Thanks, Doug. And good morning, everyone. Thanks so much for joining us for this webinar today. So I'm going to do a quick whip through a bit about our guidelines development process. Just going to put my timer on so I don't talk for too long. And then tell you a little bit about the different actionable statements or recommendations that you can find in the guidelines documents. So as Doug had says, this has been quite a long process, a long but rewarding process, I can tell you. And I appreciate everyone who's been involved so much in this project. So as Doug highlighted, we had a very large group of people who are involved across a range of different groups, and really proud to say that in the end, we were able to achieve the approval from our National Health and Medical Research Council, which is really exciting development for us, being the first guidelines in this field to have that approval. So this just gives you an overview of the different groups that Doug was talking about at the start. So we had our project steering group, we had a research team, we had a guidelines development group, which was really where the rubber hit the road. So these guys did so much work and gave so much time to the project. And then we had a range of advisory groups who provided us with a significant amount of input and feedback that we had to work with. So we had lots of really rich information from all these advisory groups. So as Doug said, a challenge in doing this is that there is no agreement internationally about the diagnosis of FASD. So one of the first things we did is we wanted to review all the existing guidelines. An important thing to highlight is we didn't want to just review the content of these guidelines. We wanted to review how the decisions were made in these guidelines. And a big finding from this review, and this information is available for any people who want to nerd out in the administrative and technical report, but a big finding from this is that a lot of the decisions that are being made in guidelines are not actually evidence-based. So there was not a lot of evidence actually being cited for some really key decisions and differences between different diagnostic criteria. So what we wanted to make sure we did is have a very evidence-based process, as evidence-based as we could possibly be, acknowledging, of course, that there are going to be gaps in that evidence, but making sure that we're being really transparent about reporting on those gaps and really helping to, advance the field where we need more evidence to address those areas. So we undertook 4 reviews as part of this process. These have all been published in peer-reviewed journals and all have associated technical reports that are available for you to read all the details about these reviews. So Doug highlighted the first one here, which was a systematic review, looking at all the associations between prenatal alcohol exposure and diagnostic outcomes. We did a systematic review of the lived experiences of the assessment process. We did a scoping review, trying to understand what about all the other things we need to be aware of when we're doing assessments so that we can really have a holistic approach. And then we did a scoping review to really understand costs, resources, and models of care for providing assessment and diagnosis of FASD. So this was to help us to think about what other ways could we think about doing this? How could we do this differently that could reach more people, that could potentially be more accessible? And as I've highlighted, we really wanted to make sure we were undertaking a really widespread consultation process that was as inclusive as we could possibly be. So we've tried to be very respectful, very inclusive of a really wide range of diverse perspectives throughout this project. And we had a range of methods for gathering this information, which included workshops. We did multiple surveys. People could provide written submissions, verbal feedback. We really tried to capture as much of this information in as many different ways as we could. And lastly, we got that big tick of approval from NHMRC, which was really exciting for us to know that we had done this in a rigorous way that enabled us to get that really important approval for this to be a formal national clinical practice guideline. So the actionable statements or the recommendations that you'll see in the document, there's 4 different types of statements and they're color-coded here, as you can see throughout the document. So the first type of statement that you'll see is our grade-based recommendations, which are in green. We have our lived experience statements, which are in purple, our good practice statements, which are in blue, and our implementation considerations, tools and tips, which are in maybe what we would call beige. So our grade-based recommendations, these form the basis of what's included in the diagnostic criteria. So as the name suggests, these were developed from a grade-based approach, and they were based on findings of that massive systematic review and meta-analyses that we did, really trying to understand what is the association between prenatal alcohol exposure and all of the potential diagnostic features. And Delise is going to talk a little bit more about that soon. So just as an example, this is what those grade-based recommendations look like. So the next type to highlight for you is our good practice statements. So these were really developed through that massive amount of input we got from all the advisory group members and also from the results of those 2 scoping reviews that I highlighted. And these are really about supporting the implementation of those grade-based recommendations and providing lots of information. So there's lots of good practice statements, and we really hope this provides you with a comprehensive overview of the whole assessment process in these statements. As an example, here's a couple of good practice statements. So the first one there is about routinely asking about prenatal alcohol exposure. And then good practice statement 27 provides some advice about collaborative goal setting and how this can support practitioners in taking a more holistic approach to assessment. Now, lived experience statements, these are really exciting to me. I believe this is the first time that I'm aware of that a guideline has included these type of statements. These were based on our systematic review and qualitative synthesis of the lived experiences of the assessment process, and shout out to Nicole Hayes, who did that piece of work. And we wanted these to really be a way for people's lived experiences to speak directly to the clinicians. So how can we ensure the assessment process is meeting the needs of the clients, individuals and families, and making sure that it's respectful and meaningful? So I'll show you a quick example of what those look like. So for example, here, lived experience statement 5 says that understanding and receiving a diagnosis can bring about mixed emotions. Plan feedback and recommendations with this in mind. Assessment results help understand behaviour. When communicating outcomes, provide specific information and examples, clearly linking assessment results to observed or reported challenges in daily functioning to support understanding and insight. And recognise an individual's strengths and challenges to identify the appropriate supports and to facilitate positive outcomes post-assessment. The final type is implementation considerations, tools and tips. And what we wanted these to be is really those practical things to help clinicians with implementing the other recommendations. And you'll see a couple of further examples of these Prue will be highlighting for you in a little bit as well. So a couple of examples here. We've got some appendices where we've got a template for assessment around prenatal alcohol exposure. We've got a template to help you with gathering background information for the assessment. This is just an overview that provides a bit of a visual summary. So you can see the different types of statements, the different consultative groups that we had, and how this all came together with the resulting types of actionable statements. Now I'm going to hand over to Delise for the next section.
Okay, thank you so much, Tash. Okay, I think we can go to the next slide. Great. So as Doug and Tash have both mentioned, one of the challenges I think that we faced was that there was no international agreement on the FASD diagnostic criteria. So we really wanted to work to establish a rigorous, evidence-based and transparent process for developing diagnostic criteria. So the process that I'm referring to is shown here, and really there are 4 key steps which I'm going to talk you through. So the first part of this process was our systematic literature reviews, and here we looked at studies of PAE or prenatal alcohol exposure, as well as clinical studies of people diagnosed with FASD to try and capture the most up-to-date research available on the potential candidate diagnostic features. Following that, we conducted a series of meta-analyses. Now, this is a method that brings together data from a number of independent studies to determine overall trends. And here we looked at levels of PAE from light through heavy and their association with the candidate outcomes. The candidate outcomes of interest were physical size, dysmorphology, functional neurodevelopment, and structural and neurological diagnostic features. So following that through a process of consensus, the guideline development group then applied grade ratings, which Tash has mentioned, and we applied these to each of the candidate diagnostic features. So, yep, we can stay on this slide, thanks. So the NHMRC uses grade to assess the certainty of evidence and the strength of recommendations. And we do this by applying 4 ratings from high, moderate, low through very low. And just as an example, ratings tend to be lower if there might be a risk of bias or greater inconsistency between studies, whereas ratings tend to be higher when there are larger effects or evidence of what we might call a dose-response relationship. So we applied those ratings, and then finally, in the 4th part of the process, we developed evidence to decision frameworks. Now, these frameworks really provide a roadmap for decision-making, ensuring a really clear and consistent process. And the frameworks are designed to ensure that decisions are well-informed, transparent, and account for all relevant factors. And they move beyond just the evidence. So this is where we look at things like how acceptable or feasible is a framework in the real world. We can go to the next slide. Thanks, Tash. So I'm not going to go through all of this information because there's quite a lot of detail here, but this is essentially the process of those evidence to decision frameworks. Now, we broke this down into a multi-stage framework process. So first of all, we looked at individual frameworks for each of the diagnostic features we're interested in. And then we also did an overall framework that considered the diagnostic criteria as a whole. So lots of steps involved in these processes. We can go to the next slide. Thanks, Tash. So one of the challenges, nonetheless, in the FASD literature is that it's often difficult to analyse and interpret the evidence. Now, this is because different studies have different definitions of PAE and also often examine different populations. So we also created our own prenatal alcohol exposure hierarchy, which we used to summarise and categorise the evidence in how we analysed it and evaluated it. And these three main levels were exposure studies where we actually did know the level of alcohol exposure in pregnancy, studies where alcohol exposure had been reported but the level wasn't reported, and finally studies of people diagnosed with FASD. Thanks, Tash. Go to the next one. So now there's, again, a lot of information here. I'm not going to go through all of the specific detail here, but it shows a breakdown of the main types of outcomes that we looked at, which I mentioned earlier. Overall, we included 306 studies with 505 relevant outcomes, and we conducted close to 950 meta-analyses across all of these available outcomes, exposure levels, and diagnostic groups. So a huge amount of work went into all of those publications that Tash mentioned earlier. And I obviously can't talk through all of these, but I will present an example of what it actually looks like. So if you go to the guidelines, this is what you will see, and also in some of those publications as well. So this is just to give you a sense of the process. So this provides a visual overview of evidence from a series of meta-analyses on the association between PAE and small for gestational age. So the different levels of PAE here are indicated by different colours, which you can see down the middle of the figure. And also shown here at the bottom right, so you can see the actual amount of alcohol linked to each of those categories from light through very heavy PAE. And we can see here, if we look at the different colours that correlate to different exposure levels, that as the level of alcohol exposure increases, we start to see a trend towards a more meaningful effect here. So the odds increase for a relationship between small for gestational age and alcohol exposure. In this case, in the pink, the strongest relationship is for very heavy PAE. Now, along the side, there's a lot of numbers, but just to talk you through that, each point represents a meta-analysis for each of those different colour categories of alcohol exposure. The little circles represent the grade rating. So for very heavy PAE, that top category, we can see the rating is moderate level of evidence. Now that decreases for some of the other levels of evidence below. We also have information on the number of studies in a meta-analysis and the number of people in total in that meta-analysis. So again, for instance, with very high PAE, we can see there were 5 studies and 67,000 people in that meta-analysis. And below are the meta-analytic statistics for anyone interested in that level of detail. So we have lots of those in the guidelines that you can have a closer look at. Thanks, Tash. So based on the findings from the evidence review, we created the following grade-based recommendations. Now, it is important to point out that this diagnostic framework is also aligned with other neurodevelopmental conditions that are in the DSM-5 TR. So there was a pre-existing reason why we chose these particular categories. So for a diagnostic feature to be considered, we needed to know that the evidence indicated a clear association between prenatal alcohol exposure and a given outcome, and that all individuals with a diagnosis were required to show these features for diagnosis. For diagnostic specifiers, the next category, again, we needed clear evidence of association, but not all individuals had to present with these features. And for additional features, we required some or limited evidence that indicates the possibility of an association, but this is really recommended to be documented to support future recommendations and research to try and understand whether these features are something that might need to be integrated in future updates of the guidelines. So taken together, really that structure represents the heterogeneity of FASD presentations and gives us an evidence-based framework that is adaptable to new evidence. Thanks, Tash. Now, there are a couple of limitations that are worth noting, and you know, it's always some limitations, despite the fact that so much rigour has been applied to this process. Firstly, obviously, we can't control for or compare all different types of alcohol exposure. For instance, There might be instances of chronic alcohol exposure or exposure only prior to pregnancy awareness or at a particular time in a trimester in pregnancy. And due to that variability in definition, we weren't able to look at all of those categories across studies. But as more research emerges, we may be able to look at some of those different categories of exposure. Another limitation is that prenatal alcohol exposure is typically based on self-report, and whilst this does remain the most accurate method to assess PAE at the moment, because we don't have biomarkers or biological screening tools, it can be prone to limitations such as memory recall bias or underreporting in some cases due to stigma. So we have to be mindful of that limitation. And the final limitation was that where possible, we did look at outcomes that had been adjusted for other factors that might influence the relationship between PAE and a given feature that we want to look at. However, of course, it's not possible to control for all the factors in the prenatal or postnatal period that might have a relationship with prenatal alcohol exposure. So future research again is needed to strengthen our evidence around that. So finally, for anyone who's interested in a little bit more detail, they can have a look at the technical report. There's a publication in BMC Medicine and obviously the guidelines themselves. And now I'm going to hand over to Prue. Thanks, Tash.
Thanks, Delise. So the first of the diagnostic criteria we'll be talking you through is the prenatal alcohol exposure. I'll just go to the next slide. In chapter 4, we've just highlighted some of the key sections. I think these are the chapters people might want to flick through to when they're actually looking at, how are we going to do diagnosis. So this is just a snapshot of where to find information. In terms of criterion A is about evidence of prenatal alcohol exposure. So we need confirmation of prenatal alcohol exposure above a low risk level at any time during gestation. In the absence of that, we can confirm prenatal alcohol exposure through the presence of the 3 sentinel facial features. And the way that this is categorised is by using the audit C, which provides for, if there's an audit C score of less than 3, it would be considered low risk. So we're looking for where the audit C can be completed, we'd be looking for a score of 3 or more. And this is detailed further in chapter 6 of the guidelines. So this is just a bit of a snapshot to show what the evidence was in relation to different levels of alcohol exposure. So you can see in the light alcohol use, light exposure, which correlated with an audit C score between 0 and 2. This is considered, it's sort of defined as being up to 2 standard drinks a week or 20 grams of alcohol. And what the evidence review found was that although there's potential for some adverse outcomes, it's a very low likelihood that this level of alcohol could cause the degree of neurodevelopmental challenges that are seen to get a FASD diagnosis. We wanted to make it really clear that that doesn't mean that low risk alcohol is not harmful, but there is not evidence that low level alcohol can cause the range of impairments that we see in children and young people and adults with FASD. The strongest evidence was for heavy and very heavy alcohol, as you saw on Delisa's sort of evidence tree, at least on one of those criteria for growth. You could see that heavy and very heavy had very strong evidence compared to the other levels of alcohol risk. We have the confirmed unquantifiable group in the middle. There are a number of studies where alcohol could not be quantified, but there still was a demonstrated strong effect. And so we thought it was important to recognise that there may not always be information that allows us to categorise the amount of alcohol, but some clinical judgment is needed in that area. And then we have the moderate alcohol category, which goes between 2 to 10 standard drinks a week. And again, there are mixed reviews, mixed findings for this level of alcohol use, but you can see that the moderate range could comprise a binge drinking pattern, or it could be more like a light pattern. So again, clinical judgment and discussion is needed to determine, for each person whether it's considered that the alcohol can be confirmed above a low risk level. And I'll just go to the next slide. So the Audit C is contained in that appendix with the practitioner tools. And you'll notice that this one has a few changes to the one in the previous guidelines. If we can click through, we have a pre and post pregnancy recognition score. And that's based on understanding that some people will, when they're being asked about their alcohol use, they may not differentiate. So we want to make sure we capture that pre-recognition pattern of alcohol use. If there are different scores, we would use the higher score in calculating risk, because that's the period that we're interested in. We don't add the scores or average the scores out. It's really about identifying the period in which there was a risk. And one more change to the Audit C you'll notice is that question 6 talks about how often did you have 6 or more standard drinks on one occasion. Now, this is a change from the previous guide, but it's actually fidelity with the original Audit C developed by the World Health Organization, which has 6 drinks in it, which is based on 60 milligrams of ethanol. And over time, over the last decade, this has sort of morphed in Australia in some places to, say, 5 drinks. We think this is because 5 standard drinks in the US is equivalent to 6 in Australia, so their American version says 5. But also the NHMRC guidelines about risky drinking being more than 4 drinks, we think it sort of got mixed up in there. There are many organisations in Australia that currently use the 6 drinks question, and so we're really reverting to the original format of the Audit C, and there'll be some more work put out to help people clarify that if you're using versions of the Audit C that have the 5 drinks for question 3. So just the last thing I'll say is we will be creating some more resources that will be available to people to help interpret this in their practice. And I'll hand over to James.
Thank you. So similar to the 2016 guidelines, one of the criteria for diagnosis is that there's presence of clinically significant impairments in 3 or more neurodevelopmental domains. Next slide, please. And so, like many diagnoses, we have a line drawing problem in which we have many domains that are continuous variables, and we need to make a decision about what level constitutes impairment. So in the evidence review, there wasn't any real clear cutoff score indicated from the evidence that differentiated people with different life outcomes. So we really are encouraging practitioners to use the best clinical judgment in terms of making a decision about what constitutes impairment, thinking about what level of score, level of challenge will have an impact on life outcomes. Next slide. So the graph here shows the sorts of scores that we might consider to be impaired. And so in the guidelines, we outline that exceptionally low or below average scores may be considered for impairment. And the lower the score is, the more likely is that you consider to be impaired. The previous guidelines used a cutoff of less than 3rd percentile. We're no longer using that. And part of the reason is that many scores, including scores below the 3rd percentile, the confidence interval of the score will actually cross multiple descriptive ranges, such as shown in the graph of the shaded area. So because of that, we really are encouraging practitioners to think about where the true score lies and the impact on functioning, and look at other sources of information to help determine what score is likely to be impaired, really thinking that it's functioning that's impaired, not an individual test score. Next slide. And so in doing that, we encourage the use of standardized tests, and we would recommend that you choose standardized tests in line with how you would practice more generally and what other good practice points there might be. We haven't prescribed any particular test, and we haven't required the use of tests as such, because in some cases the test might not be appropriate for people, and there might be other barriers to getting accurate test score, such as sensory motor impairments or language barriers that mean you might need to use a more holistic testing approach. So we really encourage practitioners to think about the use of standardized tests along with other source of information that may help inform your judgment, and to consider particularly the language and culture background in your choice of tests and how you interpret the test, bearing in mind that there's no tests that specifically normed to Aboriginal and Torres Strait Islander people that would be appropriate for use in assessing all the domains. And we also encourage people to think about how the test scores map onto neurodevelopmental domains, thinking about what the scores actually measure and reflect rather than just what the label reflects. And to provide further consideration about scores near the guidelines, as indicated on the previous slide. Next slide. So here are the domains as they were in the 2016 guidelines. We have brain structure and neurology, motor skills, memory, executive functioning, attention, language, adaptive behavior, cognition, academic achievement, and affect regulation. Next slide. So in the 2025 guidelines, we have made some changes to the domains, but many of the domains remain quite similar as before. So the brain structure and neurology domain is no longer directly considered as one of the domains, as there wasn't sufficient evidence in the review to support the inclusion, although microcephaly is still included, which I'll discuss a bit later on. We have revised the definition of all of the domains to try and make the descriptions more clearer and provide further guidance for practitioners about how you actually apply the guidelines to an individual case. So in doing so, we tried to discourage any use of a tick box approach and to really think about the scores in the context of other information. Some domains have been changed in terms of the name, but remain largely similar. So the language domain is now referred to as communication, which still reflects how it was applied in the original guidelines. Cognition is similarly changed to intellectual abilities, as that really better reflects the previous definition and the current definition in the new guidelines. Different scores are no longer included under the intellectual domain because those didn't reflect differences in levels of impairment. And academic achievement is now renamed literacy and numeracy skills to provide more clarity about the scope of that domain. We've also revised the executive functioning domain to provide a more focused definition of executive functioning, rather than including ADHD symptoms such as hyperactivity and impulsivity. These might still be considered under the domain, but we really want people to think about how this might differ from the attention domain as well. Motor domain remains quite similar, but we're trying to capture a broad level of motor impairment rather than individual skills such as writing ability. And the adaptive domain has been revised to focus on adaptive functioning and not including social communication and pragmatics. And autism spectrum diagnosis no longer fulfills criteria for this domain, as again, it wasn't supported in the evidence review. Next slide. So the emotion regulation domain is the most substantially revised domain with the guidelines. And this follows both the evidence review and the advice from lived experience groups, where we're really trying to capture more broad-based emotion and behavior regulation problems rather than focusing on specific diagnoses such as depression or generalized anxiety disorder. The evidence review included a bunch of different broad measures of internalizing and externalizing behavior, such as the strengths and difficulties questionnaire and the child behavior checklist. So practitioners might consider this in how they apply the diagnosis, but the domain covers a broad range of abilities, including mood, emotion regulation, and behavior regulation. As discussed previously, many of the evidence reviews weren't able to exclude other covariates, but practitioners should really consider causality in terms of how they apply this in other domains, trying to ensure that the difficulties with emotion or behavior regulation are persistent across time, present in multiple contexts, and not due to other factors such as recent life events or family system challenges. And to also consider about how the person may have had access to intervention, the family history of similar problems, and other factors that might also contribute to these difficulties. Next slide. So in young children, microcephaly may also be used as an indicator of impairment. We've used the wording may be in the guidelines to recognise that practitioners should be provided flexibility in how they approach this. Some practitioners felt that it was appropriate to provide a diagnosis at an early age based on microcephaly and other signs of impairment, noting the benefits of early intervention and that there might be challenges in accessing reassessment for families in some situations, particularly in rural and remote areas. So we want to provide choice in how this is approached. Other practitioners also noted concerns that microcephaly might not always reflect permanent neurodevelopmental impairment, and so that might also weigh in decisions about how to approach diagnosis. In making a decision, we encourage people to think about, again, information overall, particularly other signs of developmental delays or other risk factors that might increase or decrease your confidence in diagnosis. And regardless of whether or not you're making a diagnosis at the time, to try and plan for early intervention and try and get people access to supports, which can also be done with an at-risk label if delays are present. Next slide. So the next criterion is that the impairments must result in functional impairments that require significant supports across multiple areas of functioning relative to the person's developmental stage and cultural context. Next slide. So in determining that the functional impairments require support, we really want people to be looking at the connection between the impairments themselves and the need for support. So the support needs shouldn't be due to other factors that are not related to prenatal exposure or the underlying impairments. And practitioners should again be using the clinical judgment to determine what is a significant level of support. And also the adaptive behavior domain might give some guidance around kind of what the support needs are and the association there. But this requirement is broader than just the adaptive functioning domains in the guidelines. And we should also be considering other factors that might also influence support needs. We focus the definition on the need for support, noting that some people may in fact be quite well supported by family, school, and other factors in their life that mean that they don't require, that they're not showing clear impairment of their day-to-day functioning, but considering that if those supports weren't available to the person, they would then be showing those impairments. Next slide. So the next criterion is that the onset of impairment is during the developmental period. So in determining this, this will often be straightforward for assessments in children and adolescents, but FASD diagnosis can be made across the lifespan. And in adults, it's important to establish that the impairments were present in the developmental period and that the overall pattern of evidence supports this. In establishing this, we're not strictly requiring any assessments, knowing that this might not always be possible, but we want there to be evidence present in the history or interview or other information that supports the presence of impairments overall. It'll often be the case that present from quite an early stage, including early childhood, but some domains may develop at different rates over time, and it's important for practitioners to distinguish between normal variation in abilities and normal variation in development, and a change from typical that might constitute an impairment. There may also be variation in the rate at which different domains develop. For example, motor and cognition domains may develop earlier on and may be more accurately assessed earlier on, whereas other domains such as executive functioning may develop later and might require assessment in later life or later childhood to fully determine when those impairments are present. And as such, there may sometimes be a need for repeat assessment over time, but the key factors in determining this domain are really to ensure that there hasn't been an acute change from baseline and there's not an acute condition impacting the performance, and that these things are likely to be stable across time, as FASD is a lifelong diagnosis. Next slide. So the next criterion is that the presentation is not explained by other factors, such as another condition or exposure. So in practice, this domain can be quite hard to determine, as often prenatal exposure co-occurs with other conditions. Some of this may be comorbid to FASD, and some of these factors might better explain the person's presentation, and often there's a judgment required to determine which category things better fit into. So we encourage practitioners to really make sure that they do a comprehensive formulation to consider all these factors that might be present, and particularly to consider that many of the impairments in your developmental domains will not be specific to FASD, and that many conditions may also present with impairment in 3 domains, such as intellectual disability, for example. And so conditions such as intellectual disability may be presenting with FASD, but other factors might require further consideration. So in particular, we want people to be looking at other predisposing factors, such as the family history or of learning problems or intergenerational trauma, other genetic conditions that may be present that might potentially offer a better explanation for the conditions, which might include things such as Fragile X, other prenatal exposures such as other substances, or any birth complications, postnatal factors, particularly adverse childhood experiences and other conditions such as brain injury and other neurological conditions that may be present, and also current medications and substance use. In general, practitioners should be applying a higher threshold for impairment when there's more factors present, and to really consider about what's the most likely explanation for underlying difficulties that are present in the person. Next slide. And so finally, practitioners should also know any incidental facial features, head circumference, or physical side reduction. Next slide. So these specifiers are included in the guidelines because they help increase certainty regarding the causative role of alcohol in the underlying impairments that the person demonstrating. And as per the evidence review, we identified that sentinel facial features, head circumference, and physical size restriction are associated with the impacts of prenatal alcohol exposure and should therefore be included in the recording. In noting this, you should note whether 0, 1, 2, or 3 facial features are present, the extent of any head circumference restriction both at birth and postnatally, and similarly for physical size restriction, including specific measurements and the percentile or decibel changes. Next slide. And so we've offered 2 diagnostic terms in the current guidelines. The first term is fetal alcohol spectrum disorder, which was used in the 2016 guidelines and is also used throughout the document. This label is often taken to indicate a causative role in prenatal alcohol exposure in the person's impairments, as implied by the use of the word alcohol in the diagnosis label itself. Next slide. We've offered an alternate label instead that's consistent with DSM-5-TR, which is neurodevelopmental disorder associated with prenatal alcohol exposure. There were a diversity of views about these labels in the guidelines from both clinicians and lived experience groups. And we're really trying to offer choice and control for families and practitioners about what label might be most appropriate. And we really encourage a shared decision-making approach in determining what's the most appropriate label for the person. The reason we've suggested this label as a potential alternative to FASD is this both aligns with current diagnostic labels in the DSM and also highlights that prenatal alcohol exposure might coexist alongside a range of other factors that might also contribute to the person's underlying difficulties, and it can be challenging practice to determine which factors are most significant in a single individual. So that's my bit. I'll hand over to Max for his part.
Thanks, James. Appreciate that. So I'm here to talk about the assessment process and a few other bits to round us up. I'll try to be comprehensive and quick as we're heading towards time. So the development of the assessment process itself was built upon the systematic review of lived experience of the assessment and diagnostic process and resource implications and models of care scoping review. Both of these documents are available for people to read and download and read themselves. Additionally, they drew upon the priority setting survey, advisory groups, and guideline development groups. So a lot of people putting a lot of work into this. The process presented in the guidelines can be completed either in one setting, where this is an option, like a multidisciplinary clinic, or across multiple settings. Resource limitations, particularly regarding lack of specialist services, is in areas such as rural regions, well understood by everybody present here today. So in the development of the guidelines, a key takeaway message is that the assessment process aims to encourage all practitioners, regardless of setting or discipline, to contribute where they can. Doug touched on this earlier at the beginning, I note, and particularly removing the need for people to move to the cities, as he so eloquently put it, to get a FASD assessment and diagnosis. Obviously, there'll still be challenges in access to services. The guidelines themselves cannot fix health access, but we hope we have managed to remove a few barriers. Those involved in the development also felt very strongly about access equity, and we hope that the assessment process offered will facilitate this in part, and I guess future work in this area would obviously be very welcome. So there was a FASD Indigenous framework was kind of touched on briefly earlier in the presentation, but I want to highlight that it is not just a separate document that sits alongside the main guidelines. It's part of the assessment process itself. To read directly from the guidelines briefly, it is recommended that the diagnostic criteria be implemented within a dynamic, interactional, social contextual, shared decision-making approach. This approach involves clinical reasoning and collaboration with the individual and family to consider the probability of risk and individual strengths, impairments, and functional capacities, and the individual family's perspective regarding disability and diagnosis. So it's a very meaty sentence, but it just carries so much meaning in how we kind of actually want people to approach the assessment themselves. Sorry, next slide, Tash. Touching briefly on the later chapters of the guidelines, there is a lot of information covering medical assessments, functional and well-being assessments, formulation and strength-based pathways. The goal of these chapters is to support practitioners of all medical and allied health disciplines to integrate information from a range of sources while considering context, history, and needs. When taken together, it provides guidance for undertaking an assessment that is both comprehensive and person-centered. And we strongly encourage those involved in using the guidelines to refer to these chapters when applying the diagnostic process. A quick example of the good practice statements in Chapter 7 that discuss medical imaging of sentinel facial features, consideration of genetic or teratogenic causes of dysmorphic features, consideration of microarrays were clinically appropriate, physical size, head circumference, etc. Another example, Chapter 9, importantly touches on trauma and prenatal alcohol exposure, as well as co-occurring conditions and differential diagnosis. For the time poor, which is, many clinicians attending, there are a range of practitioner resources that can be found in the appendix of the guidelines. A lot of established clinics will have their own forms and processes, but I do encourage review of these templates as they may touch on topics that haven't been considered. Or for clinicians who, being part of a FASD assessment process or team, may be a newer experience. They are helpful documents, so clinicians don't have to reinvent the wheel. Within the appendix, you'll find history forms, physical assessment templates, performers, holistic formulation and diagnostic summaries, and of course the Audit C. Next slide. Oh, Tash, you're one step ahead of me. There are numerous documents that have been produced as part of the process, such as the technical reports, but also frameworks and guides that offer a lot of extra information as well. The FASD Indigenous Framework is a truly excellent piece of work that I cannot highlight enough, and hope that all will take the time to read it. Obviously, the main guidelines are long and in depth, so both plain language and brief versions have been produced as well. All of these documents are publicly available and hosted in a few places. You can find them on websites such as FASD Hub and the NHMRC. They're easily searchable as well through Google. On to dissemination activities. I'll go one more slide further. There we go. The dissemination activities are being led by members of the Guideline Development Group and Clinical Advisory Groups for each state. The planning and outreach has begun across each state. There has also been some wonderful coverage in the media. I want to take the time to highlight the clinicians who are already taking the opportunity to present the work undertaken and the guidelines themselves at various speaking opportunities. For example, Brew, who you heard from earlier, has already shared information at the Youth Justice and Child Protection Conference in the Northern Territory. And some clinicians involved are also reaching out to non-health government agencies and departments such as mental health courts. Leveraging the knowledge of clinicians in each state will be particularly important given the differences in health systems across states and the need to integrate local knowledge of said systems, such as agencies involved in assessment and diagnostic processes, knowledge of further support services in the communities, etc. Face-to-face workshops will also be an important part in communicating the guidelines around the country, and resources will be made available for ongoing support and training, and recordings from face-to-face sessions will be part of online training materials. These will be freely available for other organisations to host on their websites if they wish, or be part of local training. And my personal opinion is that any free professional training and development is always very welcome. Next slide, the dissemination activities. The dissemination will also involve providing the guidelines to diagnostic services and professional associations such as medical colleges and peak bodies. Obviously, we've touched on the NHMRC, which was, a hard hurdle to get over, but it was very welcome and I think gives a lot of credence to the guidelines. And the guidelines are obviously available to universities to update their curriculums, or in developing postgraduate training or micro-credentialing courses like the one that's run out of the University of Western Australia. And to refer back again to Prue, who alongside analysts the social worker are developing resources for individuals with living experience, which I'm very much looking forward to reading. Next slide. So there are discipline-specific interest groups that have kind of cropped up out of the guideline development process. This includes speech pathology, occupational therapy, physiotherapy, and psychology. And the relevant contacts for joining those groups are listed here. And I think that's the end of it. So I'm going to hand back to Tash to get the ball rolling on the Q&A, and to our lovely hosts as well.
Thanks, Max. Thanks, everyone. If we could all turn our cameras and microphones on, we've got a couple of questions from the chat. And I see, Prue, you've been very good at answering some of them already. So that's a couple in there. And I think this might be for you, James, from your section. There was a question about within the adaptive social functioning domain, with social cognition and pragmatics no longer included, how is social functioning evaluated?
So social functioning is evaluated quite broadly. Like, it's often a component of various adaptive measures. So the real change is that it's not focused specifically in social emotional reciprocity or pragmatic. So it really is about how they form a relationship. And so it would typically be evaluated through like parent report or self-reports and other questionnaires.
Well, thank you. And perhaps this is maybe for you as well. Have the diagnostic categories, the FASD with 3 sentinel facial features, less than 3, changed to include the other physical size specifiers such as head circumference, weight, height, length?
Probably better as a club.
Do you want me to do that one for you, James? So the change that we've made is that we're no longer calling it by different diagnostic terms based on your facial features or your physical features. So as you can see in that criteria, we want to apply those physical specifiers to everyone so we can understand what extent of physical symptoms someone has. But as Delise and James highlighted, not everyone presents with the physical features of FASD. So we're not providing FASD with or without those features, but you're providing it FASD and then specifying the level of features for everyone. So just, I guess, in a way, it sort of simplifies it, but it's a little bit different. So before you sort of had only those two categories, whereas now you've got one category and then the different physical specifiers. And again, as Delise highlighted, that structure is consistent with the DSM in that we specify different sort of groupings of conditions. So hopefully that provides some consistency as well in approach.
Thanks for that, Tash. There's a question around whether these broadened scope of the guidelines could make diagnosis a little more difficult, since there's less specific criteria to rely on and a bigger emphasis on clinical judgment.
So we hope that by reading the documents and coming to further workshops that will help people to see what we hope is that's not the case, that the level of detail that we provide in this documentation is very thorough. And we really want this to be something that people can apply across those different settings. So whilst there's some changes around, allowing, not being really rigid about tools and things like that, this actually aligns with how we already practice as allied health professionals. So a lot of the work that's been done in these guidelines has been around aligning our practices and making sure that what we're putting forward in these guidelines is actually what is best practice in assessment approaches.
Well, thank you. Is there a social work interest group is a question we have from Gemma.
Prue, let's throw to you.
Question.
I'll look to you on that one.
Good question. Certainly something we can look at. I guess it's early days for what can be provided in the dissemination phase. So we'll certainly note that area of interest. Thank you.
Yep. I think that's all the questions that I can see in there, unless any other panelists can see something in there that they'd like. There's a lot of lovely comments in there, including the inclusion of the lived experience in the guidelines as a valuable addition. But if anyone else has a question, chuck it in the chat.
I can see one there for you, Jeff, about is the alternative term neurodevelopmental disorder associated with PAE recognized by NDIS? So
Yeah.
I can say that yes, because we have been using this term in our clinic now for a number of years. So since the DSM, the new DSM was released, this term was available. And I know other clinics have already been applying and using this terminology as well in their reports alongside FASD, because people are more familiar with the DSM. So people who may not have awareness of FASD more broadly may actually have more knowledge about the DSM. So yes, we have already been using this term. Of course, there's going to need to be some education with NDIS about these new guidelines, and that's something we'll be engaging with to make sure we educate people about this. And as Prue highlighted, there'll also be a range of other resources that we're going to develop to help communicate some of these key messages as well. Yeah, Prue.
And apologies if I may have given slightly different advice in the chat, Natasha, in responding to that question, because it's not technically listed as one of the recognised disabilities in the schedules. If it's being accepted, that's great. There may be occasions where the term FASD still needs to be used until it's integrated into the NDIS sort of list of approved conditions. Would that be right, Tash?
And I guess we're in flux at the moment too, I would add, with the NDIS review. So it's going to be interesting to see what comes out of that and going forward, what it's going to look like. So I think overall it's going to need some more engagement with NDIS in general, and yeah, looking at what their process is going to look like going forward and making sure that we're getting our information to them to make sure we make it as easy as possible for individuals and families to get that access. Yeah.
The NDS also does state that FASD doesn't always meet the criterion. They're really shifting their focus to functional impairment. So the new guidelines focus on demonstrating the impact on function will also help with relatively.
Thanks for that, James. You're a little bit quiet, James, on your microphone, so just for future. But I think we got most of that. Thanks. The questions are coming in thick and fast now. So there's a question from Annette about that they currently perform microarray for usual clinical criteria. Any changes to this, given need to exclude other diagnoses?
No, there's no changes to that. So it's still recommended. In the medical assessment section, there's recommendations there. Yeah, really want to be making sure we're ruling out all other potential causes, and yeah, doing those genetic testing is obviously really important.
Yep. Thank you. There's a question there about discrepancy between the people who might rate, such as parents or teachers. What holds more weight?
I can answer that one. I don't think either necessarily do. I think this is really where a holistic assessment comes into play, right? That we need to value different perspectives on how a child is functioning, and also that children often function differently in different settings, and trying to understand why that is. Why is a child potentially coping better at school than at home, or vice versa? So I think actually valuing both rather than one or the other is where I would sit as a clinician there.
Well, thanks, Elise. There's a question around, will this allow a broader range of services to diagnose the disorder? For example, non-specialists.
Yes, that's what we hope.
Yep.
Yeah, that's our big goal, is we want this to get out there to more people. We want as many clinicians to get involved in this across different services, individual clinicians. Absolutely. That is a big goal that we have with these guidelines, is making it more accessible for people. Yeah.
Yeah. Cool. There's a question around the Indigenous version that Dave Skelton mentioned of the 2025 guidelines. I'm not sure about that one. Does that question?
I'm wondering if it's referring to the Indigenous framework that kind of more sits alongside and then it also incorporated in part. So it's a separate document. It's not a specific set of guidelines for Indigenous people or written for Indigenous people or anything like that. So
Okay. If anyone
but it
finds the
can be
link
found.
to that, we could
Yeah.
drop that in the
It's
chat to everyone.
yeah. It's both the NMHRC site and the other sites that contain it have that document sitting alongside with all the others.
Yeah,
Right.
if you go on to, I put a link at the end of their slides, so where you can access all the documents from. And when you go on there, there's just hyperlink to all the documents, so they're all available there for you. Yeah.
Great, thanks, Tash. We have another question. Is there any more research being done to use brain scans or other tests that could help diagnose when not disclosed?
Yeah, it's the what do you want to say? The be all and end all, isn't it? Like, so yeah, there's lots of research happening, particularly internationally with that. But at the moment, so we looked at all the literature, but at the moment, there's nothing there that we could use clinically yet that's has enough evidence that we'd be able to use instead of having prenatal alcohol exposure information. So still lots more to be done. That's really it'd be amazing if there was a, biomarker that we could use, but nothing there yet for us.
Thank you. For anyone who's finding it difficult to access a copy of the PDF slides, it could be a network issue. So if you copy and paste it into a browser, you might be able to access it. A few people have experienced that. So if the link isn't working from clicking it through the chat. All right, there's more. There's lots of issues in Kim, so they're looking for more support in the future, and I was thankful there. Unspecified neurodevelopment disorder space. Commonly have children with confirmed substance use, etc., but not alcohol, and they have 3+ kind of deficits. How do they get support?
Take that one and the one from playing together, just with that
Just speak up a little bit, James. Sorry, it's a little bit hard to hear. Yeah.
So I guess, firstly, we often do use the label unspecified neurological disorder when we can't make it call that kind of what requires diagnosis. I guess recognizing that like it gets to like the diagnosis. In theory, it shouldn't really be about having a specified label, because it's meant to be about the impact of function, but we do find that having a label is often helpful. It is a really hard call in practice a lot of the time to make a determination about whether or not it's alcohol or other factors. And we really encourage people to get through in detail about what the most likely cause of it. So thinking about if there's other prenatal exposures or post-natal exposures, about what would be the impact of those factors and whether that might contribute to the current presentation or explain the current presentation, and thinking about what's left over that's not explained. So it really does require you to be quite across the impacts of a range of variables that might also be co-occurring with FASD. It's very tricky in the case of other prenatal exposures because there's just not the level of evidence around to determine what's going up, what the outcome will be. And that might be a point where you might be on the NDPAE or unspecified neurological disorder label because it's that ambiguity present. We saw like a diverse range of outcomes with alcohol, and often the case for other exposures is that there's multiple exposures to different substances and that complicate things further. So it's really, really hard to separate from other exposures. So I think practice that is possible, but focusing more about how to differentiate post-natal factors such as hormone in particular and other.
Thank you. It's complex, isn't it? All right. Oh, you might need to help me with some of these questions, Tash, in terms of
maybe I can Jane's question sort of is consistent with that one that you're just talking about there, James. So obviously we didn't have time to sort of go into the nitty-gritty of all the details, but if you go and read the document under criterion E, what we really talk about there is how there can be situations, and James highlighted this a bit in what he said, there can be situations where things are comorbid and there can be situations where things are a better explanation. So that's what we're wanting clinicians to weigh up, is to really be thinking about, based on all the information that I've been able to collect, what is the best explanation for the challenges that this individual is presenting with. And that's what we hope Criterion A helps you to think about in a more holistic way. I just thought I'd add that one in for you, James, sort of related.
Thank you. There is a question around when assessing attention using other objective tests and maybe children prescribed or medicated with ADHD medications. Should they be on medications when the testing is occurring? Any commentary on that?
I can take that. So I guess it depends what the purpose of your assessment is. Like if you're trying to determine whether or not there are attention impairments and that's not already established, you might consider doing it off medication. But most of the time, you'd be trying to determine the other domains more broadly. And the guidelines encourage you to think about what might be due to attention versus other factors. So particularly things like memory, it can be quite hard to determine what's attention and what's memory itself, particularly if ADHD is poorly managed. So in many situations like that, you'd want to be trying to determine about what is the impact of those domains specifically. And ADHD medication might help get a pure profile that's not as contaminated by the factors such as attention. But if you are trying to assess ADHD more broadly, you might consider doing part of it without medication or looking at other source of information such as informant reports. It really comes back to what you're trying to be doing with your testing and how it contributes to your formulation.
Excellent. Thank you so much. There's a question there about like early consumption before pregnancy awareness and use of the Audit C from Sarah. Who's best placed to answer that question?
I could probably answer that one. Sarah's asked whether the new Audit C with the pre and post pregnancy recognition will be adopted during antenatal screening. So we'll certainly be encouraging health services across Australia to use this version of the Audit C. I know that FARE, who've conducted the Every Moment Matters campaign, are updating the Audit C to align with the revised question 3. So we'll also be encouraging that pre and post recognition. I think what we've found overall is that statewide guidelines for maternity and neonatal care can take a very long time to be updated. In many cases, they're 10 years out of date already. So my suggestion would be that services can choose to adopt this and integrate it into their practice. Yeah.
Excellent. Thank you, Prue. I think you've answered that question. I think that's all of the questions we have. Look, on behalf of, we had like over 280 people attend today, which is really big for this. So it obviously proves the need for these guidelines. And I think I can speak on behalf of everyone just how much we appreciate the amount of effort and detail and how comprehensive this has been, and how much of your lives has been dedicated to this over the past years to get it to this point. So it's a pretty impressive and formidable piece of work. So thank you so much for coming together and providing this webinar. If you put up the slides again, just quickly, Tash, there's those links to the email address where people can contact you. And we've dropped in the chat where they can find that. There they are. Thank you. So FASD guidelines at uq.edu.au, and there's the links to where the guidelines and all the accompanying resources exist, and also where they exist on the FASD hub. Please get in contact via that email address if you've got further questions, suggestions, ideas, collaborations, etc. And there's a mailing list as well on that page, so you can receive updates as well. Lots of lovely comments in the chats, thanking you for your efforts and the work. And that is it. If you just flick to the next slide. Thanks, Tash, for our webinar season for semester 1 2025. We can all have a break over the June-July holidays, and our webinar will be recommencing in August for semester 2. So thank you, Tash, James, Max, Delise, Prue, for your time. And yes, we wish everyone a great day and a great rest of the week.
Thanks, everyone.